And today our topic is the next congenital tubulopathy, that is the Bartter syndrome. And first of all, we will discuss about the definition, then we will work through all the features, then the investigation, and last is the treatment. So first of all, what is the Bartter syndrome? Let's discuss about it. It's an autosomal recessive disease that is congenitally inherited from the parents, and there are five types of Bartter. The fifth type is autosomal dominant. Okay, it's an extra edge. If you want to remember, you can. If you want to skip, you can also skip that. So it's the defect of, mainly the Bartter syndrome is the defect in the thick ascending limb of loop of Henle. Defect of the, mainly the channel name is sodium potassium 2-chloride co-transporter, that is a very famous co-transporter present in the thick ascending part of loop of Henle. So in addition to the defect in the sodium potassium 2-chloride co-transporter, there are two other channels that are independent. First is the chloride channel and the second is the ROMK. What is ROMK? ROMK is the renal outer medullary potassium channel. Okay, it's the chloride channel, renal outer medullary potassium channel. So what I'm trying to explain is that there are defect in the three channels. The main one is the sodium potassium 2 chloride, right? Sodium potassium 2 chloride is the main channel that is being defected. The second is the independent chloride channel, and the third is the ROMK channel, that is the potassium channel. Okay, so these all three channels in the thick ascending part of loop of Henle are defected. So one more interesting thing is that this chloride channel that is present in the thick ascending part of loop of Henle is also present in the inner ear. Okay, this chloride channel is also present in the inner ear, and in case of the Bartter syndrome, this channel in the inner ear is also defected, and it results in sensory neural deafness. Sensory neural deafness. And one of the important features for the Bartter syndrome is the sensory neural deafness, right? Because the similar channel is being affected in the inner ear as well. So first of all, we need to understand the what is the concept of antenatal Bartter syndrome. There are the Bartter syndrome that is common in children's and neonates, and the second type of Bartter is antenatal Bartter syndrome. What is antenatal Bartter syndrome? Even before the birth. Okay, antenatal Bartter syndrome. It is even before the birth and is also known as by the name known as prostaglandin E syndrome. The antenatal Bartter is also known as prostaglandin E syndrome, in which there is large amount of prostaglandin in the fetus. So it means that fetus is going to have the symptoms of Bartter syndrome like polyuria, right? Polyuria, salt wasting as well, right? Salt wasting. In case of antenatal Bartter, salt wasting. So it means that when the fetus is suffering from antenatal Bartter or prostaglandin E syndrome, the symptoms are same as the Bartter syndrome that is common in the children after the birth, right? And it leads to water loss as well. These all conditions combine to form a very dangerous situation known as polyhydramnios. Polyhydramnios. What is polyhydramnios? Polyhydramnios is a condition in which the amniotic fluid index is increased. Amniotic fluid index is increased. The pregnant mother will complain of belly extension, or she can complain like stiffness in the belly, right? So these are conditions in which polyhydramnios is indicated. It results in amniotic fluid index that is being increased due to the water loss, polyuria, and salt wasting by the fetus. This is the only condition in which the fetal disease, okay, the fetal disease antenatal Bartter is affecting a mother. In most of the cases, the mother takes the drug, it will affect the fetus like teratogens. The mother will drink alcohol, it will affect the fetus, but it's the solely disease in which the disease of the fetus is affecting the mother. So the next thing is that in the ultrasound, there is more than 24 centimeters of amniotic fluid index. Just an extra as if you want to remember. And this was for the antenatal Bartter syndrome. Okay, this is the prostaglandin E syndrome. Let's talk about the main features of the Bartter syndrome. The main features of the Bartter syndrome. The features of Bartter are like failure to thrive, because you know that 60% of the body consists of water, but if these channels are not functioning, they will lead to salt wasting, they will lead to water loss as well, right? So water loss, it leads to failure to thrive. And the mother may complain that my baby is not gaining weight, so that means the failure to thrive condition. The second is the dehydration. It's obvious, right? Because water loss is there, so it leads to dehydration like symptoms. And what are included in dehydration, like sunken anterior frontal, and the second is the delayed skin pinch, right? These are like symptoms, or you can physically examine these kind of manifestations. Delayed skin pinch, it is included in the dehydration. Next thing is that due to dehydration, our body has a very specific response that is known as renin angiotensin aldosterone system. Because in case of dehydration, the renal perfusion is low, so GFR is low, so kidney starts to produce renin, and then the renin goes into the circulation. It will convert angiotensinogen to angiotensin 1. The angiotensin 1 is converted by the angiotensin converting enzyme to angiotensin 2, and the angiotensin 2 will produce aldosterone, and it stimulates like adrenal cortex. That's the other story for us. But in case of dehydration, or when there is hypotension, it means that hypovolemia and blood pressure is low, the RAS is activated. It leads to the aldosterone production, that's obvious. Aldosterone production, and this aldosterone will affect on the epithelial sodium channels, right? Epithelial sodium channels in the collecting tubules of the nephron. These are epithelial sodium channels, and when aldosterone act on these channels, it will cause water retention as well as the salt retention. It means that the aldosterone tries to conserve water, it tries to conserve salt. But do you think that this aldosterone functioning or compensatory mechanism can override the pathologic process? The answer is no. The pathologic process is overriding the physiologic process in this condition, right? So, the conditions like Bartter syndrome, Gitelman syndrome can be known as secondary hyperaldosteronism, because they activate the RAS, and the serum aldosterone is going to rise in both conditions. So, secondary hyperaldosteronism. The next thing is that hypokalemia. The effect of aldosterone is to the retention of salt and water, but there is a price we have to pay, that is the loss of potassium and hydrogen. It means that even the aldosterone is functioning in our favor, but we have to waste the potassium and the hydrogen. It means that the patient is going to develop hypokalemic, hypokalemic metabolic Hypokalemic metabolic alkalosis. Hypokalemia component can be explained due to the loss of potassium, and alkalosis component can be explained due to the loss of hydrogen ions. So, and one more thing, this metabolic alkalosis that is induced due to the Bartter syndrome, it's chloride slash saline non-responsive. saline non-responsive. It means that if we try to induce saline into such patients, there will be no response because the primary problem is not hypovolemia. In case of hypovolemia or volume depletion or like the hypotension, we can just induce chloride slash saline, that is 0.9% usually, and the patient will respond, right? But in case of Bartter syndrome, the main problem is not hypovolemia. The main problem is hypokalemia. It can be hypercalciuria, it can be alkalosis, it can be hypovolemia, it can be hyperaldosteronism. So there are bunch of other problems. Despite of saline administration, the patient will not respond. That is very important to understand. The next thing here is that these all channels, like I have mentioned the channels like this sodium potassium 2 chloride, the chloride channel and the potassium channel, they all create a voltage gradient. They all create a voltage gradient, right? And this voltage gradient is used for the reabsorption of calcium, and it's very important. They are used to reabsorb calcium. But in case that in which the channels are defected, can the voltage gradient be created? No, the voltage gradient is not there, so calcium reabsorption is decreased or it is inhibited. It means that the patient suffering from Bartter will have hypercalciuria. Calcium will be lost into the urine, right? Calcium is lost into the urine. What about the magnesium? Unlike the Gitelman syndrome, in which the MRPM6 channel is defective, in case of Bartter syndrome, the MRPM6 channel is functioning, right? So there will be no magnesium deficiency. In case of Bartter syndrome, there will be no normal serum magnesium levels. The hypercalciuria can be manifested in two forms. Hypercalciuria, it means that a lot of calcium that is being drained into the urine. So first is the development of nephrocalcinosis. What is nephrocalcinosis? Nephrocalcinosis is a condition in which there is like tendency to form kidney stones, right? And the second is the renal rickets, or you can simply say rickets. Renal rickets, that is due to the calcium depletion in the blood. And the renal rickets can be of like symptoms of the renal rickets can be remembered as delayed dentition. It means that dentition is delayed. What is dentition? It is tooth eruption. Dentition is delayed, right? And the second is the short stature because calcium is necessary for the bone development. So short stature. And the third is the wide open anterior fontanelle. These are like manifestations for hypercalciuria, or in other words we can say hypocalcemia, low calcium in the blood. The next thing is that it's very important to understand, whenever there is calcium serum low, when there is serum calcium low, it will lead to the development of tetany like manifestations. Tetany, right? It will lead to the development of tetany. But in case of Bartter syndrome, why is there is no tetany manifestations? I haven't described that these patients will suffer from tetany-like manifestations like carpopedal spasm and neuromuscular excitability. There is no tetany-like manifestations. And why is that so? There is no tetany, but why? It is because that in order for the tetany to occur, the serum calcium should be less than 6, or like you can say 6 or 7, right? 6 or 7 milligram percent. But in case of Bartter syndrome, the serum calcium is low enough to cause nephrocalcinosis and renal rickets. It is causing nephrocalcinosis and renal rickets, right? But the serum calcium is low, but it's not that low in order to cause tetany. It is not that sufficient amount low that it can cause tetany. So tetany-like manifestations are not seen in case of Bartter syndrome. The next thing is that the appearance of those individuals or those neonates, they have large open eyes, right? Large eyes are there. The second is that we can see the triangular triangular face. These are like, you can say, um, visual representation of those patients that are suffering from Bartter syndrome. Large eyes, triangular face, drooping mouth. Just you need to remember these for an extra edge. Drooping mouth. The second thing we need to understand is that what is the workup for such patients? It means that what is the investigation? First of all, for the investigation purposes, we need to calculate the serum sodium and serum potassium. And in case of Bartter syndrome, both are low. Because sodium is lost due to the defect of sodium potassium 2 chloride channel, and potassium is lost due to the effect of aldosterone. But in case of Bartter syndrome, the hypocalcemia component, not hypocalcemia but hypokalemia. Hypokalemia component is severe than the Gitelman syndrome. But why is that so? First of all, you need to understand that there is defect of these channels. Okay, there is defect of sodium potassium 2 chloride and the ROMK channel, that is also leading to potassium wasting, as well as the second source for the potassium wasting is the effect of aldosterone here. It means that in case of the Bartter syndrome, the hypokalemia component is severe than the Gitelman syndrome. That is very important to remember, because in case of Gitelman syndrome, the only source for the potassium loss is the effect of aldosterone. There was no potassium channel that was affected. It was just sodium chloride channel that was affected in case of Gitelman syndrome. Next, laboratory examination we need to undergo is the 24-hour urinary chloride. And what do you think, 24-hour urinary chloride will be elevated or it will be diminished? I think because the sodium potassium 2 chloride cotransporter is not functioning, so it will lead to chloride lost as well into the urine. So 24-hour urinary chloride will be increased in this condition, right? The third important test. But in case of Gitelman syndrome, these two things were also there. There was low serum sodium, there was low serum potassium, there was 24-hour urinary chloride was elevated. But how to differentiate between Gitelman syndrome and Bartter syndrome? In case of Bartter syndrome, there is hypercalciuria. There is calcium lost into the urine. So we can check the urinary calcium as well, 24-hour calcium into the urine, and that is also elevated. Unlike the Gitelman syndrome, it's also elevated. And other important test, we can see the serum magnesium, and in case of very logically, the serum magnesium will be normal, because as I've explained that the magnesium channel that is responsible for magnesium reabsorption is present in the distal convoluted tubule known as MRPM6 channel, that is still functioning. Only the sodium potassium 2 chloride in the ascending limb of loop of Henle is defected, but magnesium channel is functioning. Magnesium will be normal. What are the treatments for the Bartter syndrome? So let's talk about the treatment aspect. So treatment. As you know that most of the congenital tubulopathies have no treatment, as in Gitelman syndrome there was no definitive treatment, but in case of Bartter syndrome there is a drug known as indomethacin. And you all know that indomethacin is a COX inhibitor. It means that it is cyclooxygenase inhibitor. But why I'm saying that the COX inhibitor will be benefited in case of Bartter syndrome? as you remember that antenatal Bartter syndrome, let's move upwards. The antenatal Bartter syndrome is also known as prostaglandin E syndrome, in which the serum prostaglandin is increased. So indomethacin is COX inhibitor. You know that prostaglandin is produced from arachidonic acid by the effect of cyclooxygenase, and when this cyclooxygenase is inhibited, prostaglandin levels will fall, and it is used to treat the antenatal Bartter syndrome, i.e. the prostaglandin E syndrome. The indomethacin is not like a proper cure for the disease, but we can say that it is used to reduce the severity of the symptoms as far as the Bartter syndrome is concerned. As we are discussing about the Bartter syndrome, one last but not the least thing is that the Bartter syndrome has the same symptoms as the chronic use of loop diuretics. If a person is on loop diuretics chronically, right, for 10 years or 15 years, the symptoms are just like as the Bartter syndrome. And what are included in loop diuretics, like furosemide. It's a very like popular drug as far as loop diuretics are concerned. Torsemide, furosemide, torsemide, bumetanide. These all are loop diuretics like bumetanide, just correct the spellings. And the last is the ethacrenic acid. Ethacrenic acid. These all are included in loop diuretics. As we are discussing about indomethacin, I can just mention here that indomethacin is a drug of choice in case of following conditions. Indomethacin is a drug of choice in case of following conditions. First is the Bartter syndrome. We have discussed like antenatal Bartter. Second is the acute migraine. The patient suffering from acute migraine, we can just give indomethacin. The third is the acute gout. Acute gout in which there is podalgia. Podalgia means that is foot pain due to the like due to accumulation of uric acid crystals in the feet. And the last is the potent, not potent but patent ductus arteriosus. Patent ductus arteriosus, the acute migraine, the acute gout, and the Bartter syndrome, these all conditions will be responding to the indomethacin administration. So this was for today. And the last thing, does it leads to hypertension? Does Bartter syndrome, I have a question for you all, that does it leads to hypertension? Bartter syndrome, does it leads to hypertension? Because there is activation of RAS, there is activation of renin-angiotensin aldosterone system, and aldosterone is functioning like salt reabsorption, water reabsorption. So it means that logically we think that when there is RAS activation there will be hypertension, but this is not the case here, because the defect originally is present in the channels that are causing polyuria, dehydration, water loss, salt wasting. It means that the pathologic process is overriding the physiologic process, that is RAS. Hypertension will not be presented in case of Bartter syndrome as well as in the Gitelman syndrome. These both are conditions in which aldosterone is elevated. These are known as secondary hyperaldosteronism, but in spite of the adequate serum aldosterone presence, there will be no hypertension because the pathologic process is there. They will stop salt wasting from the tubules, water wasting. Okay, so hypertension cannot be there in spite the RAS is functioning for compensation, right? This was for today.